Madam, we are live now. So shall I start?
Yeah. Please start.
So good evening, doctors. I, Shuman, on behalf of Shield Healthcare, welcoming you all in today's session on hysteroscopic surgery in infertility. And our guest speaker is Dr. Sarbani, madam. And it's my honor to introduce Madam. Madam did her MBBS with honors, MSOG and MRCOG1. And Madam is currently associated with Baghajatin State General Hospital as a senior resident in Kolkata. So with this short introduction, I request Madam to take over the session. And meanwhile, I request all the participants for their active participation, and please post your queries on the QA dashboard of the Shield Connect page. So once the talk will be over, we shall have a short discussion on this topic with Madam. So thank you, Madam, and over to you, ma'am.
Thank you, Shuman, for this introduction, and thank you, Shield Healthcare, for this opportunity. With this short introduction, I'll be starting on the topic, which is the hysteroscopic surgery in infertility. Okay, so let's start. For a good conception to occur, we need healthy sperm, healthy ovum, and healthy embryo, a good uterine cavity, a receptive endometrium, and patent and functioning tube. These are the general requirements for a healthy conception to occur. Now, while diagnosing a patient or the infertile couple, it has been found that the male factor is responsible for 25% of cases. The rest of the cases mostly lie on the female factors, that is almost 40 to 50%. If we can see the, the factors responsible in a female are 27% is the ovulatory factors. Tubal factors are responsible for 22% of the cases. Endometriosis in 5% of cases, 4% other, and mostly 17% are unexplained. So there is definitely a need for evaluation of the infertile couple. Diagnostic evaluation for infertility is indicated for women who have failed to achieve a successful pregnancy after 12 months or more of regular unprotected intercourse. Since approximately 85% of couples may be expected to achieve pregnancy within that interval without medical assistance, evaluation may be indicated for as many as 15% of couples. Now, in a study of 8,500 infertile couples done by the WHO, the most common identifiable female factor, which has already been told, is mainly the ovulatory factors, then the endometriosis, pelvic adhesions, tubal blockage, other tubal abnormality, and hyperprolactinemia. Uterine factors can be found only in 2 to 3% of infertile women, but intrauterine lesions are much more common in this setting. These lesions can compromise spontaneous fertility as well as reduce pregnancy rate in assisted reproduction. Published observational studies suggest that increased pregnancy rates after hysteroscopic removal of endometrial polyp, submucous fibroids, uterine septum, intrauterine adhesions, which can be found in 10 to 15% of women seeking treatment for infertility. Diagnostic hysteroscopy is the evaluation of the endometrial or the uterine cavity is a basic step in female fertility workup. Transvaginal sonography and hysterosalpingography are most commonly performed nowadays for this purpose. Hysteroscopy, however, is considered the gold standard of diagnosis for intrauterine lesions. American Society of Reproductive Medicine says that the hysteroscopy is the definitive method for the diagnosis and treatment of intrauterine pathology. Costly and invasive method for uterine cavity evaluation, it should be reserved for further evaluation and treatment of abnormalities defined by less invasive methods such as hysterosalpingography and sonohysterogram. Diagnostic hysteroscopy comprises of normal 2D, 3D, USG, HSG, for unexplained infertility, uterine anomalies prior to going for in vitro fertilization, repeated IVF failure, suspected endometrial pathology, recurrent abortion, abnormal uterine bleeding. in combination with laparoscopy and transvaginal sonography gives the complete diagnosis. Here are various diagrams showing various causes of unexplained infertility, like cervical polyp, cornual polyp, which actually blocks the passage of the sperm and the ovum and their implantation in the endometrial cavity. Indication or operative hysteroscopy for reproductive failure, like polyp, as I already told, intrauterine adhesions, misplaced or embedded intrauterine diseases, uh, tubal cannulation and phalloscopy, uterine septum, submucous leomine. Here are some diagrams showing the submucous fibroids. It's a mechanism causing infertility due to position. It's very important. Poor endometrial receptivity, degeneration with increasing cytokine production. Mainly, it hampers the implantation procedure because of location, mostly the submucous fibroids. According to the American Society of Reproductive Medicine, uh, intracavitary myomas and submucous myomas having at least 50% of their volume within the uterine cavity. Infertile women and those with recurrent pregnancy loss, myomectomy should be considered only after the full evaluation. Meta-analysis of submucous fibroid says the effect of fibroid on fertility and of myomectomy is there is improving outcomes. They concluded that fertility outcomes are decreased with submucous fibroid and removal seems to improving the pregnancy rates. Uterine septum. Septal resection improves outcome in bad obstetric history. Metroplasty, that is septate for mostly performed for septate uterus or biconjugate uterus with the history of recurrent miscarriages and infertility. And no study has been published that randomizes infertile women to treat for treatment versus no treatment. For this reason, controversy exists as to whether infertile women should undergo metroplasty. Some recommended surgery, but some not randomized data is lacking. Long-standing infertility with septum and otherwise unexplained. Hysteroscopic septal resection, microcaesars, electrocautery, fiber optic laser energy are existing for this kind of lesions. Reproductive outcomes are improved after hysteroscopic resection. Fidel et al. Evaluated the reproductive outcome after hysteroscopic metroplasty in 31 women with infertility and 71 women with miscarriage and reported a cumulative pregnancy rate of 89% at 36 months for the patients with complete septum and 80% with partial septum. Reproductive outcome following hysteroscopic monopolar metroplasty, an analysis of 203 cases evaluate the reproductive outcome of women with history of infertility or recurrent miscarriage following hysteroscopic septum resection. Term deliveries increased significantly from 2.5 to 33.5%. Laparoscopic guidance frequently is used during hysteroscopic metroplasty to reduce the risk of uterine perforation. Intrauterine device insertion for 3 months with estrogenization is only recommended for complete or wide septum. Intrauterine adhesions. Intrauterine trauma resulting from vigorous endometrial curettage after multiple myomectomy, septal resection associated with recurrent pregnancy loss. The severity of adhesion may range. And intrauterine synecdoche. Prognosis, restoration of menstrual cycle. Term pregnancy rate is 40 to 80%. Pregnancy rate 60 to 90%. Prognosis is poor for severe disease. Asherman syndrome, usually caused by pregnancy-related dilatation and curettage. There is the diagram showing intrauterine, how intrauterine synecdoche may look like. T-shaped uterus, patient with tuberculosis, narrow constricted T-shaped cavity, decreased menstrual flow and amenorrhea, metroplasty, fundal and lateral posterior operation, estrogen and intrauterine devices. Better pregnancy rate with IVF, ET. Cochrane reviews shows that hysteroscopic myomectomy might increase the odds of clinical pregnancy in women with unexplained subfertility and submucous fibroid, but the evidence is at present not conclusive. Hysteroscopic removal of endometrial polyps suspected on ultrasound in women prior to IUI might increase the clinical pregnancy rate. Now, moving on to the tubal factor for infertility. Tubal factor accounts for about 20 to 25% of all cases of infertility. It includes cases of completely blocked fallopian tube and cases with either one blocked tube or no blockage but tubal scarring or other damage. The causes are pelvic infections such as pelvic inflammatory diseases, endometriosis, which is the most common, and cause scar tissue that forms after pelvic surgery. Investigation for determining tubal pathology is shown in this schematic diagram. Moving on to the next slide, tubal and uterine factor. Mild tubal disease, surgery should be offered for it, may be more effective than no treatment. Proximal tubal obstruction, selective salpingography, hysteroscopic tubal cannulation, intrauterine adhesion, hysteroscopic adhesiolysis is likely to restore menstruation and improve the chance of pregnancy. Hydrosalpinx, laparoscopic salpingectomy or clipping prior to IVF for improved pregnancy outcome. Proximal tubal obstruction, the causes can be fibrosis and obliteration, endometriosis, corneal spasm, amorphous material, viscous secretion, mucus agglutination, stromal edema. Hysteroscopic tubal cannulation appears to be more effective than fluoroscopic guided cannulation or open microsurgical repair or IVF ET. Endometrial polyps, localized overgrowth of endometrium. Polyps can distort the endometrial cavity and may have a detrimental effect on endometrial receptivity and increase the risk of implantation failure. The gold standard for diagnosis is hysteroscopy, and hysteroscopic polypectomy remains the mainstay of management. Endometrial polyp. One Cochrane review assessed the effect of hysteroscopic polypectomy on the results of intrauterine insemination. Apparently, the hysteroscopic removal of polyp prior to IUI increases the odds of clinical pregnancy compared to diagnostic hysteroscopy and polyp biopsy only. Implantation and clinical pregnancy rate were statistically significantly increased after hysteroscopic polypectomy in a group of women with recurrent implantation failure after IVF. Now, this is a paper suggesting that the practice guideline for diagnosis and management of endometrial polyp. For the infertile patient with a polyp, surgical removal is recommended to allow natural conception or assisted reproductive technology, a greater opportunity to be successful. Hysteroscopy prior going for assisted reproductive technology, a systematic review comparing the outcome of IVF treatment performed in patients who had outpatient hysteroscopy. The results of 5 studies shows evidence of benefit from outpatient hysteroscopy in improving the pregnancy rate in the subsequent IVF cycle. Hysteroscopy prior to history of recurrent IVF failure who underwent hysteroscopy, diagnostic or operative as appropriate to evaluate the endometrial cavity. Abnormal hysteroscopic findings were found in 44.9% of patients in this study, and 75 women, that is 48.1%, become pregnant following hysteroscopy. Of these pregnancies, 36 occurred in women with corrective endometrial pathology, majority which has a polyp. Hysteroscopy in asymptomatic women prior to their first IVF cycle was found to be associated with improved chance of achieving pregnancy and live birth when performed just before commencing the IVF cycle. Endometrial scratching, that also improves clinical pregnancy rate in women undergoing for assisted reproductive technologies. Endometrial scratching involves causing intentional damage to the endometrial through biopsy or curettage. An association between endometrial scratching and an increased chance of pregnancy was first described a decade ago, although the underlying mechanism remains unknown. Hysteroscopy is in the management of infertile female remains under debate. The procedure is well tolerated and effective in the treatment of intrauterine pathologies and surgeries. The randomized trials do not clearly demonstrate that surgical correction of all intrauterine abnormalities improve IVF outcome. Observational studies suggest a benefit for resection of submucous leiomyomas, adhesion, and endometrial polyp in increasing pregnancy rates. Hysteroscopy before starting IVF treatment could increase the chance of pregnancy in the subsequent IVF cycle in women who had one or more failed IVF cycles. Endometrial scratching improves the clinical pregnancy rate in women undergoing assisted reproductive treatment. So, thank you all for your patience. And now I conclude my slide. Thank you.
Thank you very much, madam.
Okay, thank you, Shuman.
Thank you very much, madam, for this nice presentation on this interesting topic on hysteroscopic surgery and its effect in the infertility. Just give me 1 minute time to collect the question, if any, in our dashboard.
Yeah, please.
Madam, just one question I got, that is, as there is a chance of recurrence of fibroid, so what is
Recurrence of what? Sorry?
any kind of fibroid?
Fibroid. Okay.
Yes.
Yeah.
So what is the approach on treating them? All time it is not possible to do this invasive procedure. So what will be the advice or something?
Okay, that will be depending on the type of fibroid we get in the patient, and we have to know the patient profile before going for the details. And if a patient is having a submucous fibroid, because today the topic was for hysteroscopic surgery for infertility. If the patient is an infertile couple and she is having a submucous fibroid, which can be removed hysteroscopically, we can go for it. That will also depend on whether she has undergone previous surgeries at all, or she is having a recurrent one. So, after achieving a successful pregnancy, suppose after hysteroscopically removing the fibroid and we have achieved a successful pregnancy, sometimes this fibroids may slow down on their own, or with the help of levonorgestrel injections we usually prescribe in our day-to-day practice. Otherwise, we'll go for after the patient completes a family and having a recurrent submucous or any kind of fibroid, we can go for hysterectomy, like that.
Okay. Thank you very much. Okay, ma'am, I could not find any other questions. So if you allow me, then we can conclude this session.
Okay, please go for it.
So thank you very much, madam, for your valuable time and for this nice talk and valuable discussion as well. So in future also, I look forward for some valuable session with you in our platform, madam. Thank you, madam, and have a good day.
I'll also look forward in future for such kind of opportunities.